Dr. Mathew Martinez come from Morristown. He has a very interesting background, which I'll share with you. And he also was the program director at Lehigh Valley Health Network, where he helped to train Mario Caruso, who put this connection together. So kudos go to Mario for making this happen, and we want to thank him as well. But at any rate, Dr. Martinez is a nationally and internationally known expert in sports cardiology and hypertrophic cardiomyopathy. Matt is the medical director of sports cardiology at Atlantic Health, which is Morristown Medical Center in New Jersey. It's a very, very good place. And he's co-medical director there of the Hypertrophic Cardiomyopathy program. Many of you know Barry Marin and his son Marty have been involved with that, and that's really the top flight program in the country, in my opinion. Dr. Martinez did his undergraduate training at Wright State University, and then after that, pretty much went to Minnesota to the Mayo Clinic for medical school, for internal medicine training, and for cardiology fellowship. And then he stayed on at Mayo for a number of years after his training, and then finally came east to Lehigh Valley in 2009 and was there for about 10 years. Where he was the program director, among other things that he did at Lehigh Valley, and then came to Atlantic Health full-time in 2019 to work with the hypertrophic cardiomyopathy and sports cardiology programs there. Obviously, he's board certified in medicine and cardiology. He has a lot of accolades, but some things that I think people will be very interested in is that he's cardiology consultant to Major League Soccer. He's the team cardiologist for the New York Jets football team. And he works with the NFL and the General Medical Committee. And he's off to the, what is the NBA Combine, basketball? Is that what you said? Or
Yeah, that's next couple days. We got to.
yeah, so the NBA Combine, he'll be heading off shortly to there. So those of us who are interested in sports, he's very much involved as a physician, so we'd like to hear about that. But today the topic is really hypertrophic cardiomyopathy. He's got more than 100 peer-reviewed publications in all the top journals. He's spoken nationally and internationally. So we're really fortunate to welcome you here today. So without further ado, I want to turn it over to you, Matt.
All right. Thank you for the introduction. And again, I'll reiterate, thank you to Mario for the invitation. I could not be more excited to talk to you about this topic. And, there's never been a time better to be somebody who loves HCM, to take care of this group, or to be a patient. We've seen quite a growth in the last few years. I'm a clinical cardiologist. I see patients. Last year we saw over 1,800 patients with either athletes with HCM, some standard athletes with other conditions that we see, valve disease and dilated cardiomyopathies and others. And of course, the majority of that is HCM. We're going to talk about how this is a treatable disease. Let me just verify. You guys can see my screen, right?
Yes. Okay. Yes. I hope everybody can. I can.
Okay. So these are the disclosures. I throw them all in there. These are all the organizations that I work with. I don't think there's any conflict in this. I help guide Bristol Myers Squibb, and I will eventually guide Cytokinetics in terms of how they use this drug. And I educate primarily. So all of that, quote, conflict is related to education. This is on acc.org. I'm the co-director with Steve Amon for Learn HCM. It is 40 of really the world's experts on this. I would encourage you, if you want in-depth for each of the things we'll talk about today, it's an online course to consider going through that. But hypertrophic cardiomyopathy is a disease that I initially was scared of as a medical student and tried to run away from, and it chased me down because the physiology is so incredible and it is so common. Over 120 countries have described some form of hypertrophic cardiomyopathy, and its prevalence lands somewhere between 1 in 200 and 1 in 500 people. Every continent describes hypertrophic cardiomyopathy, but we still leave most folks unidentified. We know we clinically identify about 10%, but we're missing it. And there's more that need to be identified, which is where much of these initiatives are leading. And if you look at other common conditions, HIV and AIDS, cystic fibrosis, muscular dystrophy, long QT syndrome, and others, hypertrophic cardiomyopathy is more common than all of them. So if you think you're not seeing them, you probably are, and I'm hopeful that this will bring this top of mind. And if you are seeing them, hopefully this will update you on what changed a little bit in 2020 with our change in guidelines. And it's a heterogeneous disease, and it varies in its genotypic expression, its phenotype, and the hemodynamics alter the presenting symptoms, the natural history of the condition, and then what therapies we deliver. If you're non-obstructive or obstructive, those therapies can vary considerably. We define it fairly simply: hypertrophy, non-dilated left ventricle in the absence of any other cause or systemic disease, metabolic or condition that explains the left ventricular hypertrophy. So what's needed is simply LVH. So if this is a normal heart up here in the upper left, you can have hypertrophy at just the basal septum, sometimes referred to as the sigmoid septum, a reverse curve here, the classic typical HCM, maybe apical HCM, the quote Yamaguchi syndrome, or neutral subtype, or that lateral wall hypertrophy in any pattern with or without obstruction can be hypertrophic cardiomyopathy as long as you exclude other conditions. So it's really a comprehensive assessment. It requires a good history, understanding all the potential metabolic overlap, a good physical exam, an ECG, and then imaging helps guide and make the diagnosis for hypertrophic cardiomyopathy. So folks typically present in one of four ways. They're going to come to you with an abnormal physical exam. Somebody heard a murmur or found something on exam that makes them concerned. They have an abnormal echo or an ECG that's suspicious for hypertrophy or hypertrophic cardiomyopathy, or they know it, right? I got a family history of hypertrophic cardiomyopathy. I'm here to be evaluated to see if I carry that same risk as they do. So here's an example of a 35-year-old female. She's a marathon runner, and she went for an annual assessment before her race. No symptoms. She felt great, clearly class 1, preparing for her marathon. No coronary disease, no family history, no of HCM or premature death, and you obtain an ECG. So this is her resting electrocardiogram. I'll give you a few seconds to look at that. And hopefully this jumps off the page at you as a clearly abnormal ECG with deep T-wave inversions all the way out through V6. There's actually ST depressions here in the inferior leads and left atrial enlargement. This is atypical for an athlete, right? This is going to be a cardiomyopathy until proven otherwise. So ECG is, despite all the fancy imaging we do, the ECG is still a powerful tool for assessing hypertrophic cardiomyopathy. HCM and normals will have LVH criteria, so that's not as helpful, but you see it a little more in HCM compared to controls. This is a study now almost 15 years old from Lakdawala in Boston, and he found that the really key separators are T-wave inversions, like we saw in our patient, more than half in HCM. It's unusual in the controls. Beyond V3 would not be an athletic change. Q waves, more common in HCM for sure. Left bundle branch block can be seen it as well. But don't forget that about 10% of the time you're going to have a normal ECG. So when it's present, it's helpful. But in itself, a normal ECG doesn't exclude HCM. It still requires additional imaging, which we'll talk about in a minute. So if you see a typical finding of HCM like the ones above here, then obviously imaging is going to be indicated. But contrast that to sometimes I see these low voltage, atrial fib, hypertrophy on their echo, and they get sent to me for HCM. This is amyloid until proven otherwise. So the ECG not only helps you suspect HCM, but many times I will order pre-testing for amyloid just based on the ECG if someone shows it to me ahead of time. So the history and the exam and the ECG are going to be critical. Signs and symptoms are just like our marathon runner, they're often asymptomatic. These are the ones I worry about the most. The ones we have no idea if they have this condition or not, and they feel well or they push through the symptoms, as many of us do. They can present with breathlessness or chest discomfort or a racing heart rate. Some will pass out. Some pass out from arrhythmias, ventricular tachycardia being the one we worry about the most, but LVOT obstruction and volume depletion can also lead to syncope, something we need to sort out in terms of risk for sudden death. Of course, sudden cardiac arrest, hopefully they've recovered, and they're doing this as part of primary prevention. But some people are bringing me a story where they have a family member who died suddenly, autopsy showed HCM, and now they're here to see what to do next for the remainder of their family. And of course, severe LV systolic dysfunction can also be part of the condition. But again, excluding infiltrative disease, Fabry disease, absence of uncontrolled hypertension, I think the most common thing we miss is considering it's hypertension with a wall thickness of 23 millimeters when it's unlikely to cause that degree of hypertrophy, certainly thinking about HCM and then looking for other things. Carpal tunnel syndrome might point you down the TTR story. The genes are helpful. You can't really do this unless you have a clinical patient with HCM. It's an autosomal dominant condition. It's not required for the diagnosis, and it can affect MYBPC3 or the myosin protein C, MY87, the myosin heavy chain, or any of the troponins can all be related to HCM. About 16 sarcomeric genes with a ton of variation that go with it. But if you find the gene, it's a 50-50 chance others will have the condition as well. So it's not required for diagnosis. It's predominantly used for downstream testing of family members. Here's an abnormal positive for MYBPC3, but on occasion, you'll make a diagnosis of Fabry, X-linked GLA here, or TTR, amyloid, which of course now both have other therapies to help that individual, different risk, different management, whole different story. So sometimes the gene testing is helpful in diagnosis, not only in first degree relative assessment. The physical exam is still important. It's something I harp on often to our fellows. Hopefully Mario is still examining patients. You can have a bifid PMI or a carotid pulse. If you have the quote triple ripple, you've got a very high obstruction where the PMI will have 3 extra pulses. The carotid can as well. Typical findings of a loud systolic ejection murmur at the sternum. Mitral regurgitation murmur can also be heard, a holosystolic murmur due to SAM at the apex towards the axilla. And that murmur gets worse with a drop in volume. So the Valsalva maneuver is the best way probably to help separate this degree of obstruction from aortic stenosis, but a squat to stand maneuver can also help. So what you're seeing is a long anterior leaflet, systolic contraction, and that gets pushed against this enlarged septal thickening. So we used to call this the Venturi effect, but we now know it's more like an eddy current where the valve is actually pushed against it, and that anterior leaflet plays a big role in acting like a sail. So this is going to be our therapeutic intervention, which we'll talk about in a little bit. So history and exam are important. The ECG can help you, but clearly echo imaging or imaging of the heart in general is going to be critical. You have to have hypertrophy to make this diagnosis. So if you do this based on 2D or M mode, the number you're going to keep in your head is 15 millimeters. So thicker than 15 millimeters is pathologic until proven otherwise. Athletes do not have wall thickness above 15 millimeters in nearly every circumstance, and we're getting better at honing in on how often 13 and 14 millimeters is truly there, the quote gray zone. But go a little deeper, because the ventricle should also be non-dilated or small. So a small left ventricle with hypertrophy at 16, 17, 18 millimeters, at least HCM has to come to mind. If they're on a single drug for high blood pressure, it's unlikely they would get that thick, and anything over 20 is pathologic beyond hypertension without really an exhaustive search. So if you have a ventricle under 45 millimeters, the sensitivity for that is over 90% for hypertrophic cardiomyopathy. So 17 millimeter thick walls with a small ventricle, it's got to be HCM until proven otherwise. Now, it can be a challenge to measure, depending on the quality of the echo or the quality of the patient being echoed. There are some challenges with ventricular measurement, and I'm showing you here at the base, the mid-ventricle or the apex. you can over measure by going into the LV or over measuring into the right ventricular wall. I'll show you what that looks like on MRI in a bit. Here's an example of an athlete sent to me at 1.56 centimeters, said to be hypertrophic cardiomyopathy, and was disqualified. But hopefully you're seeing we're way into the right ventricle. And if you remeasure that same one, you're more like 1.1 or 1.2 at the very, very most, well within normal range for this athlete, not hypertrophic cardiomyopathy. So the ability to measure the wall is really important. I think the short axis is the best way to do it. Sometimes you can see it on the parasternal long axis like you're seeing here. Tissue Doppler is helpful in HCM. Diastolic dysfunction is absolutely the common finding. You're going to find typical type 1 diastolic dysfunction, E primes that are low in the 6-7 range, and an E prime under 9 with an EE prime over 15, again, carries a sensitivity of over 90% for excluding athlete, and much more common with hypertrophic cardiomyopathy. So in that gray zone, if the Doppler assessment is abnormal, if you have a 14, 15 millimeter thick wall with abnormal diastolic function, it's probably HCM and more testing needs to be done. Strain imaging is continuing to grow. I'm not a huge fan of strain imaging. I think when done well, it can be helpful, but when done poorly, the tracking can be an issue. But suffice it to say, in the athletes, you'd expect it to be very normal, minus 20, 21, 23, and above. And in HCM, you might see overall reduction, or you might see some regional variation like you see here in the septum. So here's two different cases. One on the left side, clear hypertrophy sent to me for hypertrophic cardiomyopathy, and the one on the right, very different strain patterns. The quote blueberry pattern on the left, or the apical sparing or cherry on top on the right. Hopefully you're comfortable looking at those bullseyes. I think the bullseyes are more helpful than the overall strain. The one on the left turned out to be apical HCM, and the other was clearly amyloid. So the strain imaging can help when it's consistent with everything else you find, but in general, I would not use it as a single marker for an identifying HCM. So here's an example of a 17-year-old soccer player I saw more than a decade ago. Breathlessness for about 2 months, and the trainer said, look, he's just not getting less breathless. Everybody else is progressing. He seems to be getting worse. No other symptoms, no family history of sudden death or cardiomyopathies. Here was his electrocardiogram. So he went on for an echo, and I'll tell you the echo was read as normal. Increased, mild increase in wall thickness, no outflow tract obstruction. The tissue Doppler shown here. And when he came to me for an opinion, this medial E prime of 9.5 was way too low for me, even though it's well within normal range. For an athlete, you'd expect it to be more like 12, 13, or higher. So we sent him on for an MRI despite normal inflow. This inappropriately reduced E prime velocity and a strain value where there was clearly differential here in the septal wall, despite an overall global strain of minus 22. So the bullseye helps in this case point me more towards the MRI. So we sent him on for MRI, which is shown here. 4-chamber view, 2-chamber view, and the short axis across the bottom, hopefully fairly obvious. Marked hypertrophy here in the inferior septum. Clear hypertrophic cardiomyopathy. Ended up diagnosing his uncle and another nephew with hypertrophic cardiomyopathy. They were undiagnosed and, of course, asymptomatic. So this is an important add-on. MRI is going to be complementary to what you're going to do with echo, even though echo is clearly the first place you're going to start. So MRI can either be these still images, right? For those who understand and look at MRI frequently, morphology, edema, T1, T2, extracellular volume, all helpful. Most of the imaging from MRI is going to be the workhorse here in the middle with cine imaging, and then late gadolinium enhancement we'll talk about in a little bit. But because it's such a heterogeneous pattern of hypertrophic cardiomyopathy, MRI helps considerably with making the diagnosis. So in this case, it's clearly hypertrophied, but where you measure can be aided in MRI compared to echo. because of your ability to image across the entire ventricle and find out where the absolute maximum wall thickness is can help you identify compared to what you get from echo. Because echo can underestimate as well as overestimate hypertrophy compared to the values you get from cardiac MRI. So it underestimates more commonly than anything, and it does that really because of the acoustic imaging that occurs with ultrasound, and it has challenges with the apex. It has challenges of the posterior interventricular septum or that anterolateral free wall just because of the nature of ultrasound. It has trouble identifying that. It can also have trouble with non-contiguous hypertrophy. So here's an example where there's hypertrophy on either side next to normal wall thickness. In the traditional parasternal long axis, when they maximize that image, they may miss it entirely. Hypertrophy on either side next to normal wall thickness may be read as entirely normal. They may not even show you the hypertrophy. So MRI can help with those who we think have a higher suspicion. The MRI aids over what you get from echo. Echo can also overestimate compared to MR. Here's an example on the left with a nearly 35 millimeter thick wall, clearly placing the patient at much higher risk for sudden death. But when you look at it on MRI, you can see that the crista supraventricularis on the right side is overestimating that. And the true wall thickness is closer to 23 millimeters, an entirely different discussion with this patient in terms of diagnosis and management implications in terms of sudden death. So the MRI really is offered to everyone with a new diagnosis, and then sometimes we follow them up if we need to, but usually with that first assessment, the MRI is going to be a powerful tool to make sure that we're truly on the right track. So once you make the diagnosis with either echo and or MRI, the patient's going to go through one of the following events. So they're either going to have no symptoms, be low risk, or be gene positive, and we're going to follow them their whole life to look to see if they develop any other symptoms. The remainder are going to go through one of the potentials seen here below, either breathlessness and symptoms, a risk for atrial fibrillation, or even a risk for sudden death. And as we started with, this is a treatable condition. We have options for all of the pathways related to hypertrophic cardiomyopathy. Now, I'm going to save this for another day. The non-obstructives are a whole different challenge. Suffice it to say, the vast majority of HCMs, only about 3% end up with needing a heart transplant, but most of this group is going to get treated like standard HFpEF. The therapies are different once you have HFpEF and non-obstructive HCM compared to this group here, which is going to be the majority that come to see you with progressive symptoms and obstruction causing those symptoms. So the symptoms are the hallmark. HCM is a disease of obstruction. If you look either at resting or provocable obstruction, more than 65% or 2/3 or more have obstructive physiology. Only a third at rest. The other third, you have to bring it out either with a Valsalva maneuver or a stress echo. So this is a condition that you have to look for obstruction, as the therapeutic interventions can vary. So the obstruction from our clear systolic anterior motion we heard about before, that you can elicit on exam or by echo, leads to ischemia, mitral regurgitation, and a diminished cardiac output. And all of that leads to the symptoms: chest pain, breathlessness, fatigue, exercise dizziness, and even passing out. So this is our therapeutic target. We're going to try and target the obstruction to relieve symptoms as the initial presenting symptom in those with HCM. Pretty standard therapy. We've been doing this for about 30 years. Most of the time, beta blockers are first line, followed by calcium channel blockers, and then in some disopyramide. I usually favor calcium channel blockers on those with chest pain as their primary symptom compared to breathlessness, but the goal is to reduce their heart rate as much as you can to improve their filling time, increase the systolic ejection period, and by doing so, you improve their overall stroke volume and their symptoms can go down quite a bit. Now, this works pretty well. The symptoms usually improve even with initial therapies, but you have to deal with some of the side effects of beta blockers, calcium channel blockers, and clearly disopyramide. I don't use a lot of disopyramide. We're on the East Coast, where I think disopyramide is used more often than it is in the Midwest. but we certainly can use it as a viable therapy. And the therapy is targeted, as I said, to relieve symptoms. There's no data to use it routinely. If you have apical HCM and you have no obstruction and no symptoms, there's no reason to beta block them down to a heart rate of 65 in the absence of symptoms. You're going to give them symptoms. And sometimes I'm removing medicines when folks come to see me. But there is a new novel therapy. It's really a change in how we're going to manage, we think, going forward HCM, but there's clearly some excitement related to it, but there should be some caveats as well. And it's the first therapy to really target the sarcomere itself. And in the normal patient, you see here actin and myosin connections. Go back to your medical school days, right? They train tracks and those cross bridges cause normal contraction. In HCM, you have too many cross bridges. You have an excessive contraction that occurs from too many of those, and the myosin inhibitors target that selectively and reversibly to try and move more from this active stage to more to this relaxed stage, and in doing so, has hopefully going to improve symptoms without too much reduction in ejection fraction. So this is a movie showing that you're going to see all these extra connections here, and the medicine reversibly binds to those to try and move more towards the relaxed stage. The theory is that it may cause reduced wall thickness. That signal is pretty tiny. I wouldn't put much faith into that just yet, but clearly it's been shown to improve symptoms. This is the first phase 3 clinical trial to show that in the drug known as mavacamten then. And it looked at a modest amount of patients. Only 123 patients were studied during this trial, and they showed about a third had a functional improvement by reduction of LVOT gradient. They had a class improvement of 1 NYH class and 2/3, and many other symptomatic benefits, a modest at best increase in peak VO2 compared to placebo, statistically significant. So pretty impressive top-line data. But put it into perspective, 30 weeks duration only 123 total, at least initially, most of them white, which I think is unusual in this day and age, and many of them were over 50 years old. So although you had 65% improvement in New York Heart Association, that does mean a third had nothing. 2/3 had a gradient reduction under 30. That means about 40% did not. You had a third meet the primary endpoint point, so 2/3 of them failed that, and you did have a modest increase of about half, but 31% actually felt worse. Because if we over relax the ventricle, then you can actually develop LV dysfunction and heart failure related to it. It's reversible, but clearly a symptom we have to be aware of. So how does it compare? So if you compare it to disopyramide in terms of residual gradients over 30, it's better, but not as good as alcohol septal ablation and nowhere near as good as myectomy. And then compared those without improvement, again, about a third had no benefit compared to the tried and true ablation and myectomy. Clearly, it's a tool, but I don't see it replacing everything else just yet. They looked at this in Valor. I wasn't involved in this study, and they looked at the same sort of group, again, about 110 or so. They looked at MAVA compared to placebo, and this was a group that was class 3, so a much sicker group than the Explorer trial. They were headed to surgery, and then you intervened with mavacamten or placebo and said, wait a second, let's see if we can prevent you or at least slow down the need for surgery. Does mavacamten have a role in that? And what they found was that, at least in this group of 110 or so, it did. Those who got therapy, only about 20% after the 20 weeks decided to go on to surgery, meaning 80% of them said, I'll just take the drug anyway, compared to placebo, a pretty dramatic improvement in class improvement from Explorer, and now a reduction in the need for surgery. This is a pretty big lift moving forward. It's the first drug, but certainly not the last. This is the Redwood, which was a Cytokinetics product of CK274, and Sequoia is now enrolling as part of their phase 3 trial. So more to come. They're certainly going to be part of our assessment. I think this class of cardiac myosin inhibitors is going to be helpful. It clearly has been shown to improve symptoms. It reduces LVOT gradient. People feel better. There was some disease modification with reduction in BNP and troponin. And what we don't know, and it did reduce the need for invasive therapies, at least acutely, but we don't know, can these serve as first-line therapies? 80% were on a beta blocker, another 12% were on calcium channel blockers. So it was additive to calcium channel blockers and beta blockers as first-line therapy. Can we use this alone? Nobody knows. But be careful. Selection is going to be the key. It can cause reduction in ejection fraction despite a reduce in LVOT gradient. So an accurate follow-up, continued management is going to be important. They're followed at 4 weeks, 8 weeks, 12 weeks, and then every 3 months by echo. Hopefully you're already saying, man, that's a lot of echoes. That's a lot of follow-up compared to a beta blocker. We don't see them usually for another year. There's a fair amount of drug-drug interactions in this group, and it can be common and significant. And there's simple drugs like Prilosec or diflucan or azoles that are used for yeast infections, really common drugs that folks can get over the counter very easily, and they have pretty robust drug-drug interactions. So we have to be careful with that. Can you use it alone? We don't know. And what's the long-term negatives of preventing this normal hypercontractile state in HCM? We're starving the heart of energy. Is there a negative to that? No one knows the answer to that either. There's no harm signal on the LTE study at about 4 years. So there doesn't seem to be, but we need more data, and we certainly need more than 200 or 300 patients to be evaluated to really know if that's true for sure. So it's clearly going to be part of our medical therapy. For me, it will almost certainly eliminate disopyramide. And when we offer it to folks, we're doing it as part of a mavacamten clinic so that we can clarify all of those potential side effects. But in those who fail that or have continued symptoms despite medical therapy, septal reduction therapy is still the mainstay of how we can have a durable response. So that can be done for intervention either by a septal myectomy or an alcohol septal ablation. We've been doing these for years and years. But how do we choose between the myectomy and the alcohol ablation? The myectomy is, I'm told, not as simple as this cartoon makes it look, but removing that increased muscle allows for the blood to go around the ventricle, the long anterior leaflet, and the obstruction is relieved right after surgery. Alcohol ablation acts in a similar way, but it finds that first septal perforator that supplies blood to the septum, injects alcohol to eliminate the obstruction, and then again, usually within a few days, sometimes a few weeks before you get the maximum response, you get improvement in obstruction with alcohol ablation. So if you look at overall survival in septal ablation or surgery, myectomy compared to septal ablation, not much different than what you'd get in the expected response, making them pretty close to being equal. But if you separate them by age, you see myectomy is the clear winner in that younger group and has a much more durable response, in my opinion, compared to alcohol ablation, especially in that young group who can handle surgery without any increased risk. So patient selection for this, much like we heard about for mavacamten, is going to be important. And then, of course, procedural expertise and experience really counts when you're doing these procedures. We have one surgeon that does them. Ben von Boxtel came from Columbia, where he trained specifically in this. He and I went back to Mayo to gain some additional pearls of wisdom from Hartzell Schaff with regards specifically, of course, to myectomy. And this is what it looks like for real. So hopefully you're not eating, and I apologize for this, but it really sends home the message where you're going through the aortic valve. It's about a quarter-sized opening where you're going to identify this area, which is white, clearly where the SAM septal contact is occurring, and then remove that extra muscle, being careful not to destroy the aortic valve and not to upset the mitral valve and cause a second disease. But it's a mechanical problem. It requires a mechanical fix, removing that increased muscle thickness like you're seeing here. I think he goes for the scissors next here. But by removing that, you are opening up the doorway, essentially, and letting more blood exit the heart as a result of this myectomy. So you can see pre-myectomy here on the left, there's not a lot of room inside that cavity. And by opening that up, the initial cut and then extending it towards the right, you can really open up the cavity. Most patients, despite the surgery, will feel better in about a week or so after the surgery. They can really see the improvement. It's the most durable repair we can perform for hypertrophic cardiomyopathy, and when done in expert hands, can be done well. When done poorly, you get like you see here. You have here where they took this giant bite and there was residual obstruction, still symptomatic after the surgery, not a good outcome. And then the one on the right where there's clearly an extra hole, right? We gave them a VSD during this procedure. We ended up plugging this. That didn't work, so they ended up having to go back to the OR after they were sent to us for this VSD. So repeat surgery, not ideal. Most surgeons are not comfortable with this. It's different than virtually every other surgery we do in heart surgery. So it really requires some focus, some expertise, and of course, volume matters with regards to this. So the more you do, the better you become. So we choose the difference based on their age, the surgical expertise available. Can they travel? Can they come to us or somewhere else? Do they have a favorable ECG? So if they have an existing right bundle and they go for surgery and we could give them a left bundle, we're going to give them complete heart block. That's not an ideal candidate for this. If they've got a right bundle branch block, they're over the age of 70, or they've got something else that increases their surgical risk, that's really where alcohol ablation and potentially medical therapy, as we talked about earlier, might have a good role in this group. What about sudden death risk? Well, it's gotten better in the last decade. We've really gotten a handle on it. And much like different than other conditions, HCM and aging is a good thing. Those over the age of 60 carry about a 0.2 or 0.3% risk of dying suddenly. Part of that's because we've selected for that group that's already alive, but the risk of sudden death goes down under the age of 60. Many patients who are presenting to me are fearful most of sudden death. We can tell them that in this older group, their risk is quite low. Now, traditionally, these are the risk factors for sudden death in HCM. Of course, if you have cardiac arrest or sudden death or massive hypertrophy or non-sustained VT or passing out. But in the last guidelines, we added a few as risk factors. So compared to 2011, we added in this enhanced LV apical aneurysm risk, extensive gadolinium enhancement or SCAR by MRI, and an end-stage heart failure. And we removed this abnormal blood pressure response to exercise, which really had very little data to support it. So we do see a lot of SCAR in HCM. About 2/3 or so are going to have SCAR in HCM, but not all SCAR is created equal. So the more SCAR you find, the higher the risk, not the pattern, not the location, it's the volume. This is a study from 2014 looking at the relationship of late gadolinium enhancement by MRI and the risk of sudden death in nearly 1,300 patients. And you can see that the more SCAR you had, the worse the risk or the increased risk for sudden death. So LGE has now been shown to predict all-cause mortality in HCM, all cardiovascular risk for mortality in HCM, heart failure death, as well as risk for sudden death. So the LGE is a strong predictor in HCM. In my opinion, it may be the strongest predictor of sudden death risk. I lean pretty heavily on SCAR burden, and its absence in particular implies a very low risk. Left ventricular apical aneurysm shown here, either a small, big, or bigger, with or without clot, was shown to be an increased risk for sudden death from Rowan at Tufts in 2017. You can see those with an aneurysm had a significant increase in risk for sudden death events compared to those without an aneurysm, and those with an ejection fraction under 50%. Obviously different than other conditions where 30 and 35% ejection fraction are in our head. In HCM, most people don't survive with an EF under 35%. They're either transplanted or they're no longer with us. So those under the age of, those with a ejection fraction under 50%, that carries a significant risk of adverse events in those with HCM. And Marty and I looked at this along with Barry and almost 2,100 patients from their center and ours, 5-year follow-up, about 8% risk for sudden death, low annual mortality. Because you use this enhanced risk stratification, they were able to avert nearly all sudden death risk with a sensitivity of about 95%. So often we want to lean on that ESC risk calculator, but the score really doesn't do justice compared to these enhanced risk factors. So the sensitivity is much greater using the current guideline for risk stratification with all the new ones we just added in compared to a traditional ESC risk score. So we leaned away from the risk score and more towards the newest 2020 version, that if you have at least one or more than one, certainly more than one, I'm going to advise pretty heavily that primary prevention ICD is going to be helpful. 0 risk factors, of course, the value becomes quite small. And then finally, atrial fibrillation. This continues to evolve. Much of the dogma that I was trained in is different than it is now. It is a common arrhythmia in HCM. In fact, it's the most common arrhythmia, occurring in about 20 to 25% of symptomatic atrial fib. If you look at those that are identified just on their defibrillator, on their devices in HCM, another 25% can be identified, meaning up to half may have some sustained atrial fibrillation, increasing their risk for stroke. And it is different than what we see in other groups. It's a much earlier onset compared to the remainder of the population. More than 35% will have their first symptomatic episode of atrial fibrillation under the age of 50, or nearly 6 times higher in age-matched comparison to general population. So this is a big deal in HCM. We talk a lot about sudden death risk, but prevention and management of atrial fibrillation is really critical. In those with HCM, they rarely tolerate it. They lost atrial contribution. They get symptomatic quite a bit. They have severe symptoms of breathlessness, fatigue, loss of power, usually within a couple of minutes of going into atrial fib. It's a serious marker for quality of life issues and a big source for morbidity. But contrary to what I was trained in, atrial fibrillation can be treated. And when treated, the outcomes, the mortality, the morbidity, really not any different than those without atrial fibrillation. So as a result of some of the studies in the mid-2015 to 17 range, we've now become more aggressive with managing atrial fibrillation. And most of it starts with stroke prediction. So unlike other conditions, the CHADS VASC score does not apply. So if you have symptomatic HCM, you have symptomatic atrial fib in HCM, anticoagulation should be considered even after a single episode. Their risk of recurrence is high, and their risk of catastrophic stroke is considerably higher than age-matched individuals without HCM, and the CHADS VASC score does not help you discern the two. So if atrial fib and HCM, anticoagulation should be the first thing you think about. Now, the guidelines, we didn't really limit the options, and this is a change for me too. Amiodarone and disopyramide are the traditional therapies that we would typically use. Now sotalol and dofetilide now become the first-line therapies for most of us for managing control of atrial fibrillation or the rhythm management related to that. Now, about a third of them will tolerate this without need for additional therapy. A third will have no benefit, and a third will require an additional add-on, just like other conditions with HCM. And most of them are going to require more than one procedure. So if you have one ablation with antiarrhythmic drug, you get about a 60% benefit. So I wouldn't go directly to ablation, because if you look just at an ablation therapy in this, they often require more than 1, 2, and 3 procedures, and it's not as successful for prevention of recurrent atrial fibrillation as a single ablation with ongoing antiarrhythmic drug therapy. You can get it up to 70, 80, 90%. So most of the time I start the drug, start to prepare for considering an ablation, and then usually use both in concert. The guidelines reflected that as well. because it's so poorly tolerated, a rhythm strategy is preferred. We're going to try and get everybody back, whether those who have symptomatic atrial fibrillation, either with antiarrhythmic drug or catheter ablation or both. If you're headed for surgery, we probe pretty hard. We do usually a week-long monitor to look to see if they've got concomitant atrial fibrillation, because during the myectomy, we can usually utilize a maze procedure, which is obviously maybe our best way to prevent recurrence of atrial fibrillation in this group. So it's an aggressive search for atrial fibrillation in those who have HCM, especially in those who are headed for surgery. And it's because of this data to early 2000s from Olivato in Italy and the United States compared to modern therapy. You can see a reduction in New York Heart Association class, a reduction in embolic events and overall mortality with aggressive therapy for atrial fibrillation and HCM. Shared decision-making is the last piece of the puzzle for this. It's a big part of how we manage patients. It doesn't matter what part of HCM we're talking about, whether it's genetics, surgery, management of atrial fibrillation, advanced heart failure therapy, or even nutrition, exercise, and lifestyle. And the guidelines are pretty clear about that. Now, for more than 20 years, we've been advocating mild to moderate recreational exercise, but we added on this lower group, whereas if you're going to try and consider competitive sports, and you've heard about many athletes considering professional sports, really requires an expert review for risk for sudden death, need for a defibrillator, what's their risk with participation in sports, and it's a to be indication. Certainly with this instance, you'd want to make sure that you ask for expert opinion regarding whether or not they should exercise. Every patient who comes to see me, whether they have risk, whether they're young, they're old, whether they're going to participate in the NBA or not, they go through an exercise plan. We have a shared decision-making discussion about who they are, what's their age, their symptoms, their distribution, how they do on an exercise performance, what are their risk factors for sudden death, and then what's their aversion to risk? Are they okay with this? Do they want to participate in sports, or can we just get them to do recreational, mild to moderate exercise so that they can improve their cardiovascular fitness? We wrote about this just late 2021
I go into the guideline.
with shared decision making, and we talked about whether or not this was important for you to first decide, are you the right person to be delivering this message to the HCM patient in front of you? So in the last few slides, hopefully I spent enough time convincing you that each patient's just a little bit different, and they should be considered individually, and there's a treatable illness here, that each patient is highly variable with a variation in management and expression of the disease in their clinical course, and there really is no typical HCM patient. So that's why we think it ought to be done as part of a program. This is the first center in the state of New Jersey, and currently the only one and the only named program in the world, with named after Shannon T. Mast, who was our first donor in 2014 to help support this program. And this is our team. You see Dr. Marin up here to the left and Dr. Rowan. They visit us from Tufts Medical Center, now Leahy Medical Center, as they've changed employers. This is our nurse practitioner, Deetra, and of course myself, seeing about 1,800 or 1,900 patients last year with HCM. We're a recognized center of excellence. That's here, over here, and we have volumes that have really allowed us to do some novel stuff, including some research trials to help better understand the condition. There's really nothing we can't handle. We have an opportunity to talk to people about surgery, about sudden death risk. And what we say is we really want to co-manage this. We want to use the primary cardiologist as the point person to help us better understand the patient. And then we introduce options to the patient in collaboration as a co-management process with the primary cardiologist. We're seeing those who have diagnosed and suspected HCM, have a genetic predisposition, maybe those that are considering advanced therapies, even defibrillators, although they are pretty common these days to be done locally. Those that have symptoms, abnormal imaging, or suspected diagnosis, especially those in young athletes. I would tell you that if you find an athlete who you suspect has HCM, it's really an opportunity to make sure that we involve multiple folks so that we can better manage them, but also that we can be sure that we have the correct diagnosis, as it can be challenging to sort out mild LVH as physiologic change in the athlete compared to pathologic change. So I'm happy to take any questions. This is my contact information. You can certainly text me or email me any questions. But any questions, I would love to hear from you. And thank you for joining me and inviting me.
Well, thank you, Dr. Martinez. On behalf of the whole group, I want to thank you. That was an outstanding review of very complex material, but you made it very clear, and we appreciate that. I also want to remind the group that this is a CME program, so we'll get CME credits. Make sure at the end to fill out your evaluation form. It was attached to the invitation. Send that back. I'd like to start off with two quick questions. We'll open it to the group, and I'll also, if it's okay, Matt, maybe we could, if there's a lot of questions, we can go a little bit beyond the hour, depending on your schedule. But
Sure, I'm in good shape.
yep, okay, good. So my couple of questions. First of all, I've shared a number of patients with your center up there, with Marty, and others, and you as well. But more keep coming. So I have a family I'm dealing with now that's interesting, at two families, separate, not related families, but the same story. A relative, a first degree relative, has been diagnosed with bona fide hypertrophic cardiomyopathy at a very good center. And now the families are coming to me who happen to live in this area and saying, well, what do we do? So I've gotten echoes on all of them, and they all have normal echoes. But we did gene testing, and two of the three family members in each family match the genetics of the person who has HCM. There's no symptoms involved, but they have the same genotype as the person with symptomatic HCM.
Yeah,
What do I tell them?
great question. So I love the way you framed it. So the patient with HCM, they get the genes, and then we use that information to sort out if others carry the gene. And then you're really describing genotype positive, phenotype negative. So if you have the gene and the echo is normal and you feel like the echo is a solid normal, very normal, and you don't need an MRI, many of those, at least initially, I'll MRI them just to keep myself out of trouble. But assuming the imaging is normal and you've reviewed it, then there's nothing more to do but follow them. And in those with genes, there's no restriction. Sorry, with genes and no phenotypic expression, no restrictions. We continue to exercise and do what they normally do. And we follow them by imaging. Now, under the age of 21, I typically image them every single year, especially if they're participating in sports. I would argue an annual imaging study and an ECG is critical. And then as they get older, we start to fall into that maybe every 2 to 3 years range, rarely beyond 3 years for me if they have genes that I'm suspecting up into the 40s for sure. And then we do some discussion about how often to more frequently follow them after that. And then I make sure that if they have children, right, if they're considering children, that we know that there's still a 50-50 chance, even if they don't have expression, that they can pass on the gene. We don't really know what triggers the gene to cause expression, but once you have it, you are at risk. It's exceedingly rare for you to convert over 50, meaning you carry the gene, you're over the age of 50 and your echo is normal. It would be very unlikely for this to be an important change for you, but because you carry the gene, we still have to follow any offspring from you. I just had a 47-year-old who was seen at 44, no issues, went to see her OBGYN, and she had a new murmur. She had new diagnosis of hypertrophic cardiomyopathy despite a normal echo 3 years ago. So it definitely can be a late onset presenter. So you're going to continue to follow them by imaging, but not really do anything else.
So that's terrific. Really encouraging. Actually, I was very happy with the fact that if they're over age 60, some of the parents are in that age range, the likelihood of sudden death goes way down. And obviously, if they don't have the phenotype yet, they're in pretty good shape. So that's good. The kids have to be watched. My
Agreed.
second question relates to athletes. I've been involved with the state of New Jersey task force some years ago through the American Heart Association, and who can play and who can't and what should be done. What's the screening? So what is happening or what should happen in high school sports or college sports? Because we're asked sometimes for Rowan University down here, other places, I want to play middle linebacker for their football team, but I have LVH on my ECG. How do we screen and how do we decide who to not let play, assuming they're asymptomatic? The symptomatic is easy, but asymptomatic feel great, but they have, their septum's 1.3. It's a little bit border. What do you do?
Yeah. So in those cases, I guess there's two pieces to this. Good history, good physical exam, definitely helpful. There's no data that shows using ECG will improve survival, right, and outcomes, but it does improve diagnosis. So if you've got the resources, people do use ECG to make the diagnosis. And then, of course, you're going to need a good plan to handle an abnormal ECG, what you do with the echo, and how to refer them out. So if you're going to utilize it, just make sure you've got a good plan for that. But once you make that diagnosis, that 13, 14 millimeters, it becomes complicated. And I would tell you that there's no great way to sort this out. I usually do an echo and MRI, and I will stress them to look for any obstruction that they didn't know that they had. And then we can decide if they have just mild LVH that needs to be followed annually, or do they need early HCM, right? Do they have a 15 millimeter thick septum? What's their risk? What sport are they playing? What position do they play? There's a different risk factor if you're a punter compared to if you're a wide receiver. So that's usually there's no cookie cutter answer for that. So I guess what I would say is that if you're in that range of 13, 14, 15, load the boat. As much imaging as you're comfortable with, a stress echo to make sure that they're risk stratified, and probably a monitor. And I would do that every year while they're playing. That's a group that we see a lot of, and we're happy to help kind of help you develop gray hair along with me to struggle through those. Those are challenges, but there's no great way out of that. And then as you get to 20 and 22 millimeters, obviously you'd want to advise that their risk may be higher and gain other expertise to make sure that they're not putting themselves in harm's way.
Outstanding. Yeah, those are tough ones. A lot of gray hair there. All
Totally.
right, well, let's open it up to the whole group. Anybody have any questions?
Dr. Martinez, this is Vivek Kulkarni. I'm one of the general cardiologists. Thank you for a great talk. I had a question for you about the patients with non-obstructive HCM, but who are symptomatic. I guess, is there, other than sort of standard heart failure therapy, is there any different consideration you have for treating them? And then the second part of the question is, are there any trials that are ongoing or planned in using mavacamten
Yeah.
in people who are not obstructive?
Awesome question. So, really complicated, really tough to treat. I start with what you said. I start with standard heart failure therapy if they can improve. We are involved in a study utilizing Entresto to look to see if that will have benefit in this group. Nobody knows the answer to that. Obviously, not FDA approved for this indication with HCM, and there are others. We're starting a trial with another drug, with two other drugs to look at non-obstructive HCM. One of them is with mavacamten to look to see if we could improve wall thickness, decrease wall stress by way of BNP and troponin. There's a signal in the other studies that suggest that it may have some benefit. That's cohort 4 of a patient with mavacamten, sort of extension of Explorer. And then there's another drug that handles a different mechanism called PFOX5, I think is what it is. And that has been shown to reduce LV wall thickness at a different mechanism, again, for that non-obstructive group. So food for thought, things are coming. They're a ways away, right? Phase 1 and phase 2 for 2 of those trials, and then phase 3 for 1 trial. Those are the three options that are coming down the line. But I'm excited that at least we're starting to focus on novel therapy specifically targeted towards HCM. So stay tuned, more to come. Heart failure therapy, and then I'm happy to see them to see if they want to get involved in that research trial.
And then one other question about mavacamten. From a practical standpoint, have you guys been having difficulty with insurance authorization or cost or access? I mean, I know you said you have a mavacamten clinic.
Yeah.
How has that been going?
It's hard. So there's only 4 pharmacies in the United States that can deliver the drug. So you've got to be REMS certified, and then you have to have the patient enroll. They have to then have all of their medicines reviewed by the prescriber. At least in this case, it's only me. In our institution, we're trying to limit it to me just so that we can keep a handle on what their risk might be. And then the biggest challenge is those follow-up echoes, right? Who's going to pay for an echo at 4 weeks, 8 weeks, 12 weeks, and then every 3 months, at least in the foreseeable future, forever. But that's a lot of echoes. And you can't give the drug until the echo's been performed. So when I give them a prescription, they only get 35 days worth. In order to get the next month's worth, they have to come get an echo. I have to look at it, make sure the ejection fraction's okay, see what the gradient looks like, titrate the drug based on that or not, and then have them do it again a month later. So it's going to be challenging. We are happy to co-manage them with you. We're trying to, for some of the referring docs I see from big groups, we're creating a way so that the echoes can be done there. I can do a telehealth visit, and then as long as I can see the images, then I can give the next prescription. I think that's going to be the mechanism. Big side effects, big drug interactions with these, and if you get an LV dysfunction, there are episodes of shock, of Takotsubo cardiomyopathy, about 8%. So for me, that's 1 a day is at risk to develop LV dysfunction. So I'm apprehensive, but certainly could be a great drug going forward.
Thank you.
Other questions out there? Well, I don't hear any at the moment, so we're good, in good shape time-wise. At any rate, again, I want to thank you for enlightening us. This opened up a lot of interest here in our group. I'm sure we'll be talking about it. I'm sure many patients will find their way to your clinic, but we'll co-manage them to not burden you. But this is a tough area. Medical, legally, we didn't touch that, but it's a tough area as well with sports. Anytime you're involved with athletes, families don't thank you when they're, future NBA All-Star, you have to say can't play. That's a tough one.
Agreed.
So, these are things we will have to co-manage. At any rate, thanks so much. We hope that next time we'll be able to host you here on campus, and we'd love to show you around. And thank you so much.
Terrific. Hopefully I can get on campus. Thanks for inviting me, and hopefully we can do some collaboration in the future. Thanks for having me.
Sounds great. Thanks, everybody.
Bye.
Please fill out your review forms, and we'll see you next time.